Okay, good morning. I am David Herzog, and on behalf of Nick Cavino, the president, and the board of trustees of William James College, we welcome you to our annual forum, Moving Beyond Stigma. Teamwork and passion created today's forum. We would like to thank our incredible planning committee and my esteemed colleagues, Dean Abbey, Allison Jaffe, Jeff Chu, Jean Frejust, and the students at William James College who worked with us. We want to thank our generous sponsors whose funding allowed us to offer this forum at no cost. Our lead sponsors are Steve and Nancy Fishman, Steve and Jill Karp, Nancy Harris, John Fish in Suffolk, and we want to thank all the forum sponsors. As we all know, the opioid crisis is severe and ever-present, devastating the lives of individuals and families, and in 2016, killing 6 people a day in Massachusetts. We lose more citizens to opioid deaths than to auto accidents and homicides combined. We cannot accept this. Last year, we held a forum in this very room entitled Thinking Outside the Box. We focused on novel interventions for opioid addiction. That forum mobilized 3 Massachusetts action groups addressing different aspects of the crisis. But all of the working groups identified stigma as a major obstacle to getting care. So what is stigma? Well, Merriam-Webster defines stigma as a set of negative and often unfair beliefs that a society holds about something. We tend to stereotype severe mental illness and substance use disorders as something shameful and out of control. This is stigma. We are here today to move beyond stigma so that every individual can ask for help and receive it. We want today's forum to inform you and inspire you to kick off a statewide anti-stigma movement. We have a wide range of constituencies represented here today. Through our collective strength, we can build a community to fight stigma and bring treatment closer to those who need it. We are pleased that today's program will be live streamed, and we're very appreciative to WCVB for expanding its reach. During the program, we'll learn about critical steps we can take to combat stigma. 1, words matter. People who develop substance use problems deserve our respect and understanding. The accuracy and compassion of our words must speak loudly. They are people with substance use disorders, not addicts and junkies. And information is key. Substance use disorders are illnesses of the brain, not moral failings. They are treatable disorders. Now, during the break and lunch, you'll meet a range of novel thinkers and professionals making solutions available. Get informed and become inspired. Join us. Let's start a movement. Thank you to our speakers, moderators, panelists. What an incredible group we have today, who represent government, healthcare, business, media, law enforcement, criminal justice, and first responders. They know the scourge of stigma and its consequences, how it leads to prejudice and isolation, interferes with science and care, and for too many, severe impairment or death. This cannot be a one-and-done event. The focus will be on action. Become informed and join the effort. We have to move forward. We can't wait, and we have to do it together. Now, a few brief announcements. There'll be a break around 10:20 to 10:45. During the break, the refreshments will be available downstairs, along with interaction with the resource tables. Lunch will be from 1 to 2. And when it comes time to audience questions and answers, we will use texting. Please text questions during the keynote presentations and panels. And the texting number, you might want to jot this down, is 1-339-502-0525. 1-339-502-0525. If you would like to join the conversation online, please use hashtag number #MovingBeyondStigma to live tweet or post about the event on your social media channels. And since we have limited time, please view the program book for more information about the individual speakers. Michael Botticelli is sorry that he'll be unable to join us today. He had a last-minute request from President Clinton to meet in New York City with him and Chelsea on the opioid crisis. So now let us begin. We are truly honored to have an introduction from Boston Mayor Martin Walsh. Mayor Walsh initiated the nation's first Office of Recovery Services to prevent and treat substance use disorders. His personal recovery from alcoholism as a young adult led to his lifelong commitment to the prevention and treatment of addiction. Mayor Walsh.
The conversation about mental health and substance use disorder is changing, even as the opioid crisis continues to sweep across every city in the Commonwealth and the country. More and more people understand that mental health and substance use disorders are illnesses. These illnesses are treatable, mainstream, and human. They are illnesses that can affect any one of us, our friends, and our family members. Addiction does not discriminate. That's why everyone deserves to help in breaking the cycle of addiction. Especially in their hour of need, people struggling with addiction deserve respect, compassion, support, and our advocacy. After all, we would only want to be treated the same way ourselves. I'm so thankful that I have had a strong community that supported me during my toughest days battling alcoholism. We share a responsibility to foster a more loving, caring, and inclusive community in our homes, in our neighborhoods, and in our places of work. We do this by listening and speaking about our experiences. Today, you will explore the power of language in fighting the opioid epidemic. How do we speak in a way that promotes tolerance and caring? What do we want to be as a community and a society? This forum will address personal, social, and institutional stigmas of mental illness and substance abuse disorders. You are going to hear the voices and the experiences of community leaders, business executives, and first responders. These great leaders share a mutual respect and a determination to find shared solutions. This work is not easy, but it is critical. And I need to stress, we need to continue this conversation outside these walls. We all have a role to play. We can start with a room without stigma today to create a Boston and a Commonwealth without stigma tomorrow. That's why I'm proud to proclaim today as a day without stigma in the city of Boston. And I look forward to working together with all of
you. We will now hear from the Office of Recovery Services, who will read the proclamation from the mayor.
Good morning, everyone. So nice to see faces so bright and early. My name is Priya Cherry, and I'm the Senior Project Coordinator for the Mayor's Office of Recovery Services, and I'm here to read a proclamation on Mayor Martin J. Walsh's behalf. Whereas the conversation about mental health and substance use disorder is changing and more people understanding that mental health and substance use disorder are treatable, and whereas 1 in 4 Americans will develop a mental health problem or will misuse alcohol or drugs during their lifetime, and whereas prejudicial beliefs and attitudes associated with mental and substance use disorders are significant barriers to care, and whereas the City of Boston thanks William James College for bringing together policymakers, academics, and business and community leaders in what we hope will be an ongoing conversation on how to eliminate stigma. Now, therefore, I, Martin J. Walsh, Mayor of the City of Boston, do hereby proclaim Tuesday, May 23rd, 2017, to be a day without stigma in the City of Boston. I call upon our citizens to join us in working to break down barriers of stigma around substance use disorders and mental illness so that we can create a more compassionate community. Martin J. Walsh, Mayor of Boston. Thank you. Thank you so much. I have the signed proclamation here for Dr. Herzog.
Thank you.
Thank you so much.
Now I'm delighted to bring you a special message from Mary Lou Sutter, Secretary of the Executive Office of Health and Human Services for the Commonwealth of Massachusetts. Secretary Sutter.
Good morning. I'm Mary Lou Sutter, and I am the Secretary of Health and Human Services for Massachusetts. Thank you for being here this morning. You're with a group of extraordinary thought leaders, people from the public sector, the private sector, coming together to deal with the stigma of mental illness and addictions. And the time is now to deal with these issues. I want to thank William James College for bringing all of us together this morning and for you to spending time on this very important subject. Because two illnesses are so stigmatized and segregated and discriminated against, and that is addictions and mental illness. They're not homogeneous illnesses, and we need to have every tool in the toolkit in order to combat the opioid epidemic in the Commonwealth of Massachusetts and to ensure that our treatment of services for people with mental illness and addictions is the very best it can possibly be. For the past 2 years, together, the City of Boston, our great Commonwealth of Massachusetts, and communities from Western Massachusetts to the Cape have come together to really crystallize our fight against opioids. At the same time, we know that opioids and the addiction and addictions do not exist in a vacuum, and underlying many addictions is a fundamental mental illness. And the time is now for us to come together and really discuss, confront, and forge a new pathway to ensure that individuals with addictions, individuals with mental illness, and individuals with co-occurring disorders get the respect, the care, the treatment that they need in order to have fulfilling lives and to recover. So thank you for being here, and now it's my great pleasure to introduce Commissioner Joan McCullough.
Good morning, everyone. How fortunate are we to have city and state leaders who are so passionate in their advocacy around this issue. I'm delighted and honored to be able to present a proclamation from our governor. Whereas the opioid crisis has become a public health epidemic in Massachusetts and the nation, and whereas the number of opioid deaths in Massachusetts has risen 500% since 2000 and 370% since 2010 to 1,979 unintended deaths related to opioid use in 2016. And whereas shame and stigma create significant barriers to seeking care in those suffering from mental illness and substance use disorders, and whereas mental illness and substance use disorders are treatable brain diseases, not moral failings, and recovery is possible. And whereas prejudicial beliefs and attitudes associated with mental illness and substance use disorders stand in the way of individuals, families, and institutions establishing resources to support those suffering from these disorders. And whereas the economic and psychosocial burdens associated with these disorders lead to devastation in the lives of individuals and families, it is time to join together to take action. Now, therefore, I, Charles D. Baker, Governor of the Commonwealth of Massachusetts, do hereby proclaim May 23rd, 2017 to be State Without Stigma Day, and urge all the citizens of the Commonwealth to take cognizance of this event and participate fittingly in its observance. Signed by His Excellency Charles Baker, Karen Polito, Lieutenant Governor, and William Galvin, Secretary of the Commonwealth. Thank you. Thank you. So there you go.
Thank you so much.
Have a good day.
Thank you, Commissioner. So now I would like to introduce our first keynote speaker, Gary Mandel, the founder and CEO of Shatterproof, a national nonprofit organization dedicated to ending the devastation that addiction causes families. He founded Shatterproof after losing his son Brian to addiction in 2011 to spare other families the tragedy his family suffered. The title of Gary Mandel's talk is Society, Stigma, Shame, and Substance Use Disorders. This is an incredible man, and we're very fortunate to have him this morning.
Dear Brian.
Dear Greg, from the moment you were born, you were the sweetest kid.
Michael, honey, you brought us such joy and happiness. Thank you for those 29 years.
Like every parent, my dream is for you to be healthy and happy and fully empowered to create the lives you really want.
I coached your Little League games for many years, and I always used to say, with the game on the line, I want the ball hit to Greg.
You were a natural leader, and so many people looked up to you. You were such an amazing person. What parent wouldn't be proud of that?
Just before entering high school, you tried marijuana for the first time with some of your friends.
It has been so difficult to watch you struggle with this devastating disease.
We know our family had a strong tendency for addiction. We all loved you so. You just needed more time to get well and really heal.
You were working hard to stay sober. Unfortunately, one night you made a bad decision, and that turned out to be fatal. You had been lifted into your car, driven to a local hospital, and then left in the parking lot. About an hour later, you were discovered, but it was too late. You had been left too long.
Since the moment when I first heard of your death, I agonized to make sense of it.
I worry that the world is not equipped to deal with the issues of addiction.
Ty, if we had the chance to do things over again, we would not let that stigma of addiction stand in our way.
Brian, losing you has shattered my life. However, at the same time, you have inspired me to make a promise. We are going to equip society to protect our children from developing the disease of addiction to alcohol and other drugs. Addiction needs a national commitment. Addiction needs a national voice.
We know your strength. Recovery is possible.
We are stronger than addiction.
Together, we can end addiction.
We are Shatterproof.
Together, we are Shatterproof. Please join us. Visit us at shatterproof.org. Good morning, everyone. And David, thank you. And I really appreciate you all being here. I've been to many conferences over the last few years related to addiction, but this is the first one dedicated solely to stigma. And it's just so needed. And I'm really looking forward to speaking with you and getting to know many of you afterward. Well, this is my son, Brian. And I'd like to begin by telling you a story of two boys. Both boys were guess I'll stand over here, excuse me. Both boys were growing up where I was raising my family in Easton, Connecticut. It's a small town in southwestern Connecticut. The year is 2004, and both boys were in high school. The first, Mikey, was diagnosed with cancer. His family was horrified. But fortunately, they were easily able to find and access the highest quality medical care, all based on scientific research. Mikey's parents told a lot of their friends, and our entire town rallied behind Mikey and his family. Parents came to their home with cooked meals, drove carpools. Kids in elementary school held bake sales on the weekends to raise money for Mikey and his new charity. And the whole time Mikey was sick, as you'd expect, he received all the love and compassion that anyone with a disease could ever dream of. Well, 2 streets away, my son Brian was also struggling with a disease. But for Brian and our family, it was different. We struggled in isolation. We looked for medical care for Brian also, but we couldn't find any that was based on scientific protocols, research. Couldn't find it. We didn't tell too many of our friends. We were embarrassed about what Brian was struggling with, and our community did not rally behind us. No one came to our home with cooked meals, no carpools, but most importantly for Brian, no bake sales. The disease my son struggled with was addiction. A little bit more about Brian. From the moment he was born, he was the son I'd always dreamt of. Always smiling, hugging me, my little buddy. As a young boy, he did many of the things that young boys do. He used to play in his room with his trucks forever, or run around the backyard chasing butterflies. And as he grew into a teenager, he did many of the things that teenagers do, including trying pot. But for Brian, that's where things totally changed. His use escalated, and he became addicted. Over the next 8 years, his use escalated further and further into harder and harder drugs. And he attended 8 different treatment programs. Every one of these treatment programs was different, except for one common element. Not one of them treated my son with protocols that were based on science, on research. And there was also one other common thing. Unlike with Mikey, who was struggling with one thing, a disease, Brian struggled with 2 things. Not only battling his disease, but also constantly battling being stigmatized as the bad kid. I remember those years like it was yesterday, good times and bad times. There were times when Brian just wouldn't listen, and it was a struggle to get him to enter treatment and follow what was suggested. But there were other times where he was in treatment and he was so enthusiastic about beating this disease. I remember one time visiting him at a treatment program in Florida, and I got up early and walked into his bedroom, and I couldn't believe it. He was already up, and he was reading his treatment guide. As I walked in, he looked up at me with that big smile of his, said, "Dad, I'm getting it. I'm gonna beat this thing." But addiction always doesn't work that way. On October 20th, 2011, I was woken up in the middle of the night by my cell phone ring. And when I picked it up, I was told my son Brian had died. He was 25 years old, and he hadn't used a substance in 13 months. And even more tragic, it's why we're here today. It wasn't just addiction that took Brian's life. It was the feeling of shame that he had every morning when he opened his eyes, a feeling like an outcast that caused him to wake up that morning. And the history on his computer shows he first researched suicide notes. And then he wrote a note of his own, lit a candle, and took his own life, alone.
I wish I could tell you that my anguish has dulled in time, but it hasn't. It intensifies in me knowing that my son died of a disease that is preventable and we don't prevent, that is treatable and we don't treat, that is undeniable and we continually deny. And ever since that day, I've continually asked myself the same question. If both boys had a disease, why are these stories so different? Science tells us that addiction is a disease like any other. Its causes are genetic, biological, and environmental. But so many in our society disagree. They say those with this disease have a character flaw. And they and their families are isolated, judged, and stigmatized, and silenced. And often those who need the help the most don't get it. The answer to my question? Mikey was a patient, and Brian was an outcast. Well, a few weeks after Brian died, my wife came into our bedroom and found me crying on the bed. I thanked her for framing the Serenity Prayer and placing it on my nightstand, and told her the only thing that was keeping me alive was reading that first sentence over and over again. God, grant me the serenity to accept the things I cannot change. As the weeks and months went on, I began to read and think about that second sentence, the courage to change the things we can. I began further thinking about addiction being the third largest cause of death in this country. Every single day, 400 Bryans were dying, and no one cared. If 400 dolphins washed ashore in Florida, it'd be on CNN for a week. But drug overdoses were now causing more deaths than car accidents, and no one cared. And I began to also think and focus on the fact that for every major disease in this country, there was one well-funded national organization that was funding and pioneering private research, advocating for change, ending shame and stigma, and providing information, support, and hope for so many. And no such organization existed for addiction. And from this, a vision emerged that our society will look this disease straight in the eye, prevent it and treat it with love and empathy, with protocols based on science, just the way we do for other diseases. And from this, our organization, Shatterproof, Stronger Than Addiction, was formed. There's no question, as you'd suspect, I miss my son desperately, every day. But I can also tell you, in so many respects, I feel blessed. I've had the opportunity to meet such wonderful people all over the country. Over more than 100,000 have now joined our cause. And together, we've made enormous progress toward making our vision a reality. We've led advocacy campaigns in 13 different states, from ensuring that doctors who prescribe opioids are required to follow certain safety precautions, to protecting those who call for an ambulance for someone who's experiencing an overdose or has drank too much alcohol, to expanding access to naloxone, a medication that can immediately reverse an overdose. I'm pleased to say that legislation was passed in 12 of these 13 states, and these laws are expected to save more than 10,000 lives in the coming decade. That's a lot of lives. A year and a half ago, we were called by the CDC to ask for our help. They were scheduled to release a set of guidelines for doctors for when and how to prescribe dangerous opioids. However, the release was being threatened by powerful lobbying campaigns of several pharmaceutical companies. We immediately jumped in. We retained leading firms in advocacy and communications, and with the help of these firms and the help of hundreds and hundreds of our volunteers who raised their voices to become advocates in a variety of channels. We were successful. Davy beat Goliath, and the guidelines were issued a few months later. It's expected that full implementation of these guidelines will save somewhere between 5,000 and 10,000 lives every single year. We've created the largest event series for addiction in the history of the United States, our Shatterproof Challenge, hosting 45 of these events around in communities all across our country, where participants not only rappel off of multi-story buildings and raise valuable funding for our cause, but it's where communities come together to raise their voices, to change the conversation about addiction and end the stigma and shame, and to unite in comfort and strength, knowing they are not alone. Last year, we spent the year developing and launched in November the most comprehensive website that has ever existed for families looking for information on prevention, treatment, and recovery that's unbiased and footnoted by all the research that backs it up, completely evidence-based. And just a month ago, we announced our most comprehensive initiative to date to fundamentally change the way treatment is delivered in this country for addiction. We've brought together leading experts from both the public and private sectors, and together given ourselves a goal. By the end of the year, we will issue a new national standard of care for addiction, all based on quality measures that are each backed up by science and each have a defined way to measure them. And once this is issued, we will immediately begin implementation across our countries with both payers and providers and consumers demanding these quality measures are implemented. As much as we've accomplished, it also helps me. When I actually meet people whose lives have been saved or whose lives have been changed. Last October, I was at a meeting at the White House, and a woman came up to me and said, "Are you Gary Mandel?" Her name was Teresa. She told me that 4 months earlier, she had walked into her son, Tyler's bedroom, and found him lying on the ground, not breathing. She immediately called 911. The first to arrive was a local policeman. Because the law we had passed in her state a year earlier, the policeman had an naloxone with him and was trained to use it and administered it to Tyler and saved his life. She pulled out a picture of Tyler, and we hugged, kissed, cried, and as we did, I was thinking she may have been thanking me, but what she was really doing is thanking all those who have joined with Shatterproof to support our cause in so many different ways. I was in one of our repelling events in Milwaukee a few years ago. In the middle of the event, a woman walks up to me and starts hugging me. Then she stepped back. She said, "I'm sorry, I just had to hug you and thank you." She said, "My brother Joey has been struggling for the last 3 years, on and off, addicted to drugs. I've kind of written him off as a loser. He wasn't trying hard enough. And then I heard about this repelling event coming to our town, and I read about the event, and I went onto your website, I learned about Shatterproof and your message. And it hit me. I woke up this morning, first thing I did is I registered to repel, and then I called Joey. I apologized to him. I told him I had been looking at it wrong. He wasn't a loser. I was proud of him, of how hard he was working to battling a disease. And I told Joey I was going to repel in his honor that day, and when I got to the top of the roof, I was going to shout his name. No more shame, no more stigma. It's another family in Fairfield County near where I live. Their son's in recovery out in Southern California. We were holding a repelling event out in Orange County where he lives, their son. His mother flew out last year to repel with him to support our cause. He wouldn't come. He didn't want to be associated with an organization related to addiction. He didn't want anybody to know that he was in recovery. He was ashamed. So his mother repelled alone and flew back to Connecticut. Well, he just called me a month ago. He was one of the first to sign up for Orange County coming up next month. And he told me he invited his mother to fly out with him, and they're going to rappel together. Because of our message. He's now going to be a leading ambassador for us out in Fairfield County. It's lives changed. You can talk in the thousands on a piece of paper, or you can talk about individual lives. But I'm here to say, as much as we've done, we have to do more. And so I'm here to ask for your help, all of you. Your help in changing the way that we think about addiction, the way we talk about it, the stigma we attach to it. We don't ask cancer patients to line up in public shaming rituals to get their chemotherapy. We don't tell epileptics that the very medication that can save their lives cannot be carried in an ambulance. We don't tell a diabetic who's just had a setback, you must go to jail. As our new Attorney General would like. But we do all of these things with those who are addicted. Stigma extinguishes the very hope and self-respect that someone battling a tough disease so desperately needs, deserves. And let me be the first to say that I get it. I understand. Those with this disease can often make poor choices. And you may ask, well, they just stopped using. I used to ask the same thing about Brian. Brian, can you try a little harder? Why can't you? I didn't know the answer then, but I know the answer now. Brain scans have definitively proven without any doubt that those with this disease, two regions of their brains have been chemically altered, making them incapable of making decisions, incapable of resisting urges, just like the urge not to take a drug. Incapable. No different than someone with diabetes who is incapable of making the decision to have their body produce enough insulin. So I ask all of you, is it possible, each of you, that stigma has altered your thinking? Are there some of you in the room here today who have a family member who's suffering from this disease? And has stigma caused you to be ashamed to tell others? If it has, how do you think that makes that family member who's with this disease, has this disease, feel? Are there other of you in the room here today where addiction has not touched your family? And has stigma caused you to say or think, this could never happen to my child. I'm too good a parent. In the same way that drugs distort a drug user's thinking, is it possible that stigma has altered yours? If we can change the way and shift the way that we think about addiction, in the same way that we have shifted our thinking about HIV/AIDS, more people will feel loved and connected. More people will seek treatment. Fewer will die. Fewer will have their lives shattered, as has mine. One of the things that I'm most proud about and excited about in this coming year is a new event series that we are launching. I mentioned our repelling events, but this year we're launching an event series to signify coming out of the darkness into the light, leaving stigma behind and coming into light, into hope. We're launching 5Ks in 5 markets and bringing thousands of people together at each event. And I'd like to show you this short video, which I think shows this message really well.
Addiction is a dark place. The stigma, leaving people isolated, alone, and ashamed. But just as each new day breaks, there's light. A light that illuminates the people by your side. someone in front of you who's been where you are, someone behind you moving forward. You are not alone. Out of the darkness, you are walking with 22 million others struggling with addiction, and millions more who love and support them. The cure to darkness is light. The cure to stigma is love. And the cure to disease is treatment. Join us as we walk into the dawn of a new day. Together, we are stronger than addiction. Together, we are Shatterproof. Rise up. Join the Shatterproof 5K walk.
I truly believe, I wish with all my heart that video existed when Brian was alive. It would have changed, it would have relieved some of the anxiety, the stigma, the shame. And I wish so much he could have watched that and joined our events. But it's going to help a lot of other people. We are launching in 5 cities, as I mentioned, and Boston is one of them. And you can learn more about it on our website. I'd like to close with a story, another story. The last time Brian came home, I think about it all the time. It was 4 months before he died. He came home for a visit. And the last day, played golf in the morning. We had a family barbecue at night. And after everyone went home, Brian and I were sitting on the back porch talking about our favorite topic. I apologize because I'm here in Boston. It was the Giants and Eli Manning. And then the conversation turned to recovery, his recovery. He looked at me. He said, "Dad, someday people will realize I'm not a bad person. I just have a bad disease, and I am trying my absolute hardest. I promise, Dad." Well, the someday that he spoke about has been way too far off in the future. Because in the few minutes that I've been up here now, 6 others have died in the United States alone. And 6 other families shattered beyond anything. And you know what I wonder? I wonder the simple things. What were their names? Was there a Brian among them? When they were little kids, did they play peekaboo with their parents the way Brian used to do with me? So for their sake, addiction must be dragged out of the shadows and put right into our hearts. I cannot imagine a more perfect expression of humanity. Thank you so very much. Thank you.
Now, Gary's going to be here for a while, but we'll have time for like one question now, and then we'll keep. They're going to.
One question?
Sure. So one of the questions that we have here from one of our text messages says, "I am a substance use disorder clinician at a methadone clinic. My clients are heavily stigmatized and accused by everyone from family members to primary care physicians of substituting one drug for another. How can we all combat the stigma of medication-assisted treatment when those, even in high offices, are speaking out against it? Also, how can clinicians on the front lines be supported in delivering treatment when there is such a focus on the medication only?"
What was the second question again?
When there's such a focus on the medication only.
Sure. The first one's easy. Americans have shown time and time, and it's not going to come from up top. It's going to come from all of you in this room and millions of Americans like you, hundreds of thousands and millions all across this country. Americans have shown time and time again, whether it's women voting, people with color being treated equally, of all different races being treated equally, HIV/AIDS, on and on and on. It doesn't come from up top. It comes from a movement of people. People coming together and demanding it. So I encourage all of you to help us with that. Go to our website, put your email address and zip code, And zip code's important because when we work on changing and creating change in your state, you'll then get an email for those with a zip code within that state will get an email informing people of what we're doing. I would also encourage you to come to our walk in Boston and tell people you know in other cities. That whether it's if it's 2,000, we have a voice. If it's 3,000, we have a greater voice. If it's 4,000 people there, we have an even greater voice. To bring everybody together with one unified voice. That's how change is created. And it's done time and time and again. We don't have to recreate the wheel. We have to follow the methods that have been done for other movements and create it here. So please join our movement and tell everybody you know. If everyone here joined our movement and each told 5 people, that's a big deal. For the second question, it's all about education. It's medication assisted. Well, back to the first question, because you're referring to Attorney General Sessions. There is no way he is going to, and you're also referring to Secretary Price, who came out against medication-assisted treatment. So both of them. There is no way that we unite 1 million people around this country who counter what those two want to do, that they will be successful in implementing what they want to do. It's all a question of people. And as far as the second one, I think you're referring to the assisted treatment part. It's not just medication, it's medication-assisted treatment. It's assisted by therapy, and it's assisted by love of your family, and it's assisted by no shame and no stigma. And that all comes again back to the first point I made. It's enough people together, united within one organization and empowered to create change. Getting policies changed, getting regulations changed, getting a system of treatment changed. It's really no different. It's all people. So that's the answer.
Yeah, but I want these panels. Yeah. Yeah. Thank you. Hey, great to see you.
Good morning. Well, that started us off on the right foot, and we're going to continue in this panel, which looks at personal, social, and institutional journeys dealing with stigma. I want to introduce you to my panel, and then I'll tell you who I am at the end. So, farthest away from me is Hanner Hernandez. He's in long-term recovery from addiction, and Dr. Hernandez is an instructor at the Brown University Center for Alcohol and Addiction Studies and director of the Latino Behavioral Health Workforce Training Program at AdCare Educational Institute in Worcester, Massachusetts. He's also a senior consultant to the Massachusetts Department of Public Health Bureau of Substance Abuse Services. I'm not going to do everybody's, the whole long thing, so you can hang with me here, because everybody has long resumes. Next to him, John Rosenthal, Meredith Management, a real estate development and management company. He's very active in environmental issues, as well as social and economic justice. In 1987, you may remember that he started the Friends of Boston's Homeless, and in 1995, he founded Stop Handgun Violence, which has been the lead advocate for Massachusetts' effective gun violence prevention laws and initiatives. But for this conference, I think he's best known for then, or should be known for, is in 2015, John and former Gloucester Police Chief Leonard Campanello co-founded the Police Assisted Addiction and Recovery Initiative to support the Gloucester Police Angel program and help other police departments address the opioid epidemic. And within 18 months of its founding, the Angel program placed more than 530 people into treatment, and right now, over 200 police departments nationwide have replicated all or part of the Angel program. Dr. James O'Connell is graduated from the University of Notre Dame, Cambridge University, and Harvard Medical School. After completing a residency in internal medicine at Massachusetts General Hospital, Dr. O'Connell began full-time clinical work with homeless individuals as the founding physician of the Boston Healthcare for the Homeless program. And with his colleagues, he established the nation's first medical respite program for homeless persons. He's the author of the book Stories from the Shadows, Reflections of a Street Doctor, and the president of BHCHP and an assistant professor of medicine at Harvard Medical Center. In April of 2016, last year, he established the Supportive Place for Observation and Treatment. You may have heard of this. It's called SPOT. It's located next to the Access Harm Reduction, Overdose Prevention, and Education program. They provide needle exchange, among other services, on behalf of the Boston Public Health Commission. So, Sarah Whitman, Medical Director of the Substance Use Disorder Initiative and the Addiction Consult Team at Massachusetts General Hospital, and she's co-chair of the Mass General Opioid Task Force and clinical lead for the Partners Healthcare Substance Use Disorder Initiative. Dr. Whitman is also an assistant professor in medicine at Harvard Medical School, and she is involved in recovery services, of which we've heard of before. So that's our panel. Please give them a round of applause to begin with. My name is Callie Crossley. I'm at WGBH. For people who can't remember, that's God Bless Harvard. Now you will not forget. You will not forget those call letters now. That's one of the public radio stations here in Boston. I host a program called Under the Radar with Callie Crossley and other programs on WGBH. So our focus is to really just talk about stigma. And as I was listening last night to people talk about it, it turns out that stigma is the underpinning for everything. When you talk about addiction at all, it underpins every single thing. You can't really talk about treatment. You can't really talk about progress. It's the stigma that's holding everything down in a way that's very powerful, and more powerful than you might think if you think of what stigma is, because it feels as though that's something we can put aside when you have concrete ways to address this problem. I should note that nearly 2,000 people died of opioid abuse last year, and something interesting happened at the first quarter of this year. There was evidence there's been a slight drop in some of the areas of Massachusetts, not everywhere, and it's not enough to call it a trend, but that just wanted to give people a sense of where the numbers were in terms of opioid abuse in Massachusetts. So Dr. Whitman, let me start with you, because we want the on-the-ground experience that you have about how stigma manifests when you're dealing with the patients that you deal with.
Yes, I think your point that stigma is a part of everything, from treatment to the experience for people with this disease to the language that we use. So I'll actually focus on language first and call sort of everyone out, including our agencies, that we use terminology like abuse when we talk about addiction. So the word abuse actually comes from a word that means a willful act of misconduct. And there's no other medical condition that we would refer to that way. So I don't say to my patients with diabetes that they're sugar abusers. I don't refer to a patient with an eating disorder as a food abuser. And so with our language, we're saying to people with this medical disease that they are the same as child abusers, people who commit sexual assault. Those are the terms that we use abuse for. So I think the first thing is that it's so pernicious we don't even hear that. Other examples, we talk about people's toxicology being dirty. We call people in recovery clean, implying that someone who's still actively struggling with the disease is dirty. So this is a whole set of words and a language that we would never use when we're talking about other medical illnesses. So I think that really sheds some light on the perniciousness and sort of the pervasiveness of stigma. I think the other thing is that we often think about stigma on an individual level, and yet just like any other marginalized condition, any other sort of ism, I think sometimes the most dangerous sorts of stigma are actually the structural forms of stigma, so the ways that our system is really set up to punish people who have this disease, and that happens everywhere, from the care they receive in healthcare settings to the types of treatment that are offered to them and onward. So I think there's many, many examples.
From language, then we have in our minds, I think, about certain populations, Dr. O'Connell, what we already think about them, and you're dealing with homeless people. So already we think, okay, you know, that's a problem right there. So if we apply then some of the language that Dr. Wakeman has said is so hurtful, what do you see on the ground that really manifests itself in the stigma directed toward the people that you're trying to help?
Yeah, what Dr. Wakeman just said just rings so true for us. But then if you add on that someone is homeless in addition to all that, then you sort of get a magnification of the stigma in a way that is both troubling and kind of a struggle for all of us. I was thinking in that beautiful presentation earlier, if that had been the son of someone with no family or no home, it would have been magnified immensely. And I guess some of our struggle is how to understand that homelessness itself becomes a stigma for many people, and frequently it's the substance use issues that have sort of rendered people homeless because of the loss of all those connections. So it's actually a big struggle. I would probably just add, as Sarah knows all too well, is that we've learned among homeless population, for example, certainly the one in Boston, that opioid use disorders are now the leading cause of death, just overtaking cancer incidentally. But then even when we looked at the medical issues that people are dying from, the cancers, it turns out most of the cancers are lung cancers and liver cancers and things that are related to long-term use of cigarettes or tobacco and long-term drinking. So, substance use seems to become part of our world no matter which way we look. And if I learned anything, at least speaking as a doctor, I was on call this weekend and I got a call from one of the local hospitals that we love, from the surgical intensive care unit when one of our folks who was found outside had fallen down, had what's called the subdural hematoma on his head, was in the intensive care unit for 24 hours, and they were calling to say we're going to be discharging him home, which means home to a loading dock that he sleeps on in South Boston. And I was kind of horrified, but the residents and the surgeons and the folks in the ICU didn't feel they had any other options at that time. So I still think we are when you add homelessness to the mix, we add just another immense bit of confusion to the whole treatment scene. And the only other thing I'd say is I love what Sarah was just saying, and somebody keeps beating us up about using even the word medication-assisted treatment, because I think as a doctor we don't think of of insulin as a medication-assisted treatment for diabetes. We just think of it as the medicine for diabetes. So in some way I think even we have to in our own world start thinking we're treating people with medication for their illness, and stop thinking it's like assisted of some kind. Just a lot of little trick, and we examine ourselves all the time and realize we're using words that are really increasing the stigma rather than getting rid of it. Thank you.
So John Rosenthal, in some ways, you've already reversed the stigma, because the assumption would be all cops, substance
Use disorder.
Yeah, use disorder. I'm trying to figure out not to say abuse. Arrest, that would be the paradigm, but you've shifted that in getting police officers to think about this as a disease, really, and then that it needs a different kind of response from first responders like themselves. So I wonder if you could talk about, sort of the ongoing stigma that is associated with substance use disorder, and also your ability to begin the effort of reversing some stigma around what should be the response of first responders.
Sure, and I come from a world of changing public policy around homelessness, the stigma associated with homelessness, trying to change the conversation which we did pretty successfully in Massachusetts when we started talking about the fact that 25% of the homeless population work regular jobs and can't afford housing when average rent is $1,600 and minimum wage is $800 a month. Do the math. So by changing the conversation, reducing the stigma around who's homeless, we started to be able to raise additional funds from the legislature, and Massachusetts is a model for reducing homelessness compared to the rest of the nation. We did the same thing with gun violence. And it was the voice of law enforcement that I engaged in dealing with gun violence. The first responders who were given, 13 to 17 rounds in their service weapons, while Congress says it's fine for criminals to have 100-round magazines without a background check. So we started to break down the root causes of gun violence, and we became the model for reducing gun violence in this state for the nation. So working with law enforcement, this conservative voice of law enforcement that people are not used to saying no to. We all grow up learning not to say no to police officers. And it's remarkable how treatment centers are the same way. So the Gloucester police chief had 6 overdose deaths in the first quarter of 2015, recognizing he can't arrest, law enforcement can't arrest their way out of this epidemic. Decided to do something different. So we invited people into the police station starting on June 1st of 2015. Anyone with the disease of addiction could come into the Gloucester Police Department with or without their drugs, not be shamed, blamed, or stigmatized, and be helped into treatment. Police stations are open 24/7, like emergency rooms. But unfortunately, the stigma associated with this disease versus diabetes, you name it, cancer, you would never be turned back to the street if you presented to an emergency room. Instead, we've had police chiefs say that the executive of the local hospital was going to file a suit against the police for doing a program like this because, sending people to emergency rooms with the disease of addiction causes so much turmoil and chaos in the emergency room. Therefore, we've got to take care of real patients. That is what this healthcare system has been about for a long time with this disease. So police are now inviting people in, and the results have been incredible. So not only have 530 people come into the Gloucester police station, been treated with compassion and placed into treatment same day. We have 300 treatment centers across the country who wanted to join this effort, and over 256 police departments are replicating the model in 30 states, and roughly 10,000 people in 2 years have been placed into treatment through police departments. And the goal is to work our way out of this, but it's the conservative voice of law enforcement that has helped change the conversation. And the New England Journal of Medicine just did a piece in December on our first year of operation and reported out that 95% placement rate through the Gloucester Angel program versus 50 or 60% through emergency rooms, which just points out how broken the system is, that police can place people into treatment quicker and better than the healthcare system. So we've got to work our way out of this. Law enforcement is willing to be the voice of reason here and help change the conversation, but ultimately it's the healthcare system that needs to be blind to one disease versus another. And the voice of law enforcement has helped change that conversation nationally, and we were a part of the 21st Century Cures Act, billion-dollar funding that President Obama signed into law last year. And we're working with the White House Office of National Drug Control Policy now, but as you will see, this president has proposed a 95% reduction in the White House Office of National Drug Control Policies, and it's going to require a lot of, as Gary said, a lot of public involvement. But I will tell you that this conservative voice of law enforcement that treatment centers don't say no to, legislators are in the same position. So when it was announced that there would be a 95% reduction in ONDCP, within 2 days we had 117 police chiefs from across the country sign a letter saying don't do it, and it has an impact. So this voice of law enforcement's been a leader, but the healthcare system is really what's got to catch up.
Thank you. Dr. Hernandez, it seems to me that you have dealt with stigma in two ways. First, as a longtime recovering person yourself, and then as somebody dealing in a space of people of color where this particular kind of disease, we're now going to acknowledge that all diseases are equal, but certainly addiction associated with people of color has been the worst stigma. You're the pit's the worst, and it's all because of you. We've heard all of that. So how have you seen it on the ground? Give me some real-time stories of what you're seeing and possibly how it might be changing.
So, good morning, and thank you for the invitation. I'm going to say some things that are probably going to make some people feel uncomfortable. And nothing ever changes unless we feel uncomfortable. And in my life, things have changed because I have felt uncomfortable. So if you feel that way, it's a good thing. It's a good thing. First of all, I don't think that we can talk about stigma. And by the way, I encourage everyone to go to the SAMHSA website and read some recommended language that they have to talk about stigma. And actually, they're recommending that we don't use the word stigma, that we talk about discrimination, that we talk about racism, that we talk about things and how they hurt people. Because stigma has a funny way of meaning different things to different people. And we need to get at some very specific things. I don't think, and they introduced me as Dr. Hernandez. My name is Janer. I went from prison to treatment, not because I wanted to, but because that was the choice. And I want to connect that to this conversation on stigma. I don't think that we can talk about stigma without talking about mass incarceration. And even if your kids are not going to jail or haven't been in the criminal justice system, you should really think about that connection. 1970, 200,000 people incarcerated in the US. Fast forward to 2017, 2.3 million people incarcerated. That is not by accident. Those were very specific policies that we have developed in this country and implemented with a lot of fervor that have landed us where we are today. If we add anywhere from 5 to 7 million additional people who are under house arrest, some type of bracelet, probation or parole, we're talking close to 10 million people who are in the criminal justice system. And we can say all we want, and I believe that addiction is a disease. I believe that. I know the science, I've read it, I'm still learning about it. We can say addiction is a disease all we want, but what speaks louder? Our policy positions or us talking about addiction as a disease? We have mandatory minimums, we have school zones, we have zero tolerance laws, we have a number of policies that have been developed and implemented across the US that speak louder than words. And right now, we're talking about a crisis that has been going on for decades, but now we call it a crisis because young white people from the suburbs are dying. And listen, for me, this is both personal and professional. And we should be talking about a crisis, but we should acknowledge that this crisis has been going on for a very long time. Young black and brown people have been dying in our streets, and what we got in the 80s, 90s, and the 2000s are prisons and jails. The day after this current president got elected, the private prison industry, their stock went up 30%. That should tell us in terms of what's coming by way of a difference in relationship to policy. So I don't think that we can talk about stigma unless we talk about mass incarceration. And we can't talk about mass incarceration unless we talk about disparities. And we can't talk about disparities unless we talk about racism, disproportionate impact on Latinos and African Americans, and how our treatment system has been designed for white males. And if we don't wrap our heads around that, we'll be talking about stigma for the next 50, 60, 100 years. We need to change the mentality in terms of how we talk about this issue. And some people will say, oh, you're very passionate and animated. Of course, I was in prison. I didn't read this at the university in a book and then learned about it there. I experienced it firsthand. And I continue to do that on the ground, working with people. Yesterday, a friend called me and said, my daughter, man, she's dying. So it is very personal, right? And that's one thing that might not have made some people in this room feel uncomfortable, but there's some more stuff to follow a little bit later on in the conversation that might make us feel a little bit more uncomfortable.
Well, let me pick up from what you've said, because if we think about it, a number of you here are dealing with populations that don't immediately draw empathy. And yet we're here to undermine this overlay of stigma however we see it, which means some people may not get the treatment they want, it's not viewed in the same way. So how do you begin to make that more appealing? Really, that's the only word I can use, to those people that we need, that Gary and all of you will say, we need all these other people to say, enough of this, things have to change. Sarah, I'll start with you.
Well, first, I think amazing comments so far. Just picking up on the mass incarceration piece, I think we talk a lot about drug-related harms. What we don't talk enough about is the harms of our policies. That actually, many times using drugs is not the thing that's causing death and infection and the negative outcomes of incarceration. It's actually our policies. And this has been shown time and again in research. And a big study out of Hopkins actually just reviewed 106 studies that looked at the negative impact of drug policy on HIV and found unanimously that driving HIV infections is drug policy. So I think unless we have the courage to actually look at our drug policy, we're not going to see meaningful change. And it's hard to talk about this as a public health crisis when we're still sending people to prison every day. Millions of people are incarcerated because of the fact that they have this illness. So I think that's important. I also loved what John said about trying to put themselves out of business. I heard the former Gloucester police chief talk about the program, and he made the joke, which I think is very accurate, that an emergency room calling the police department for help with addiction would be like the police department calling the emergency room for help with a burglary. You know, that's not something that happens, and we would think that's crazy, and yet somehow it seems normal that police should be the entry point for people with a medical illness to get into science-based treatment. So I think the very fact that we need programs like that is absolutely a sign of the failure in the healthcare system. I think, you know, all of these patient populations are stigmatized, and I always get back to language because I think it's so subtle and so important, but any language that sort of communicates this us versus them, that addiction or incarceration or any of these issues or homelessness or something that happened to those people and not to our people and not to us, I think creates that divide and makes it easier to sort of support policies that punish people, that ruin lives, that ruin health. And so bridging that divide, I think, is crucial.
Well, I think that's important, but what I'm trying to get at is that, and I understand you've addressed part of that, is that if you don't have, this is from somebody working in media, no empathetic person for which the majority of people can relate to, then you do not, your story does not get heard or read. So how do you get heard or read to get people to understand that this stigma that we're talking about, which manifests itself in all the ways that you have said, is really impacting all of us? You know, that this is how do you make really the business case, if you will, for the rest of us who may not have a loved one or may not have had any interaction in this way yet. We know it's coming.
Yeah, so I mean, I'd love to think that science and studies changes people's minds. Unfortunately, that doesn't for the most part, but story does, and having people willing to speak out and share their stories. And in particular, narratives of science based approaches. We heard Gary mention that you know, the evidence base for opioid use disorder, as an example, is that medications for addiction treatment, not medication-assisted treatment, is the most evidence-based approach that increases the likelihood of remission and saves lives. And yet we have Secretary Price and many others dominating the narrative that these are somehow replacement addictions or not truly treatment. And people who themselves are doing fabulously in recovery are scared to speak out about the fact that they're on medications because they're widely stigmatized. They're stigmatized in their own recovery support groups. They're stigmatized by community members. And people have this negative image of what it looks like to be in recovery with medication. So even the terminology methadone mile, which we hear all the time, and there's been efforts to change that to recovery road, but unfortunately people still refer to it as methadone mile. And they mean that in a derogatory way to refer to people who are actively struggling with the disease. The fact that we would try to be derogatory to people struggling with the disease is a problem in and of itself, but lumping together the most effective treatment in with that bucket, I think, does such a disservice to what that looks like. And I have patients who work at Harvard, who work in our fabulous academic institutions, who are lawyers, who are on medication treatments, on methadone treatment, doing wonderfully, and no one knows because of the stigma. And so I think, you know, it's hard to ask people to speak out when they're going to be punished for doing so. And so it's this sort of chicken and egg thing that we need to educate, begin talking about this, changing policies, and we also need brave people who are willing to share their stories of what really treatment looks like and what recovery looks like.
So, I mean, and others should jump in, because that to me is the crux of this conversation from all of you. And I think, Dr. O'Connell, I wondered, when STOP started, did people who are coming into the hospital for other reasons, and they say, oh, well, this is interesting, but I mean, how did that, do they get to have a better understanding? Does it make people more comfortable? Like, people are coming to get their, you know, we're watching them. They clearly have a disease they're struggling with, but they haven't harmed me. Do you know what I'm saying?
Yes.
Oh. Mm-hmm.
No, you know, in sort of in full embarrassment, I realized that, so we have a STOP program, which I think people know, which is called a SPOT, which is a safe place for observation and treatment.
I'm sorry.
No, I did the same thing. And it came out of a very simple observation. We are at the corner of Recovery Road or Methadone Mile, where if you map out overdoses in the city, it's by far the most common place for overdoses to occur. And it's a collision of many social and economic factors that happen to concentrate things there. But in our building, we were having so many overdoses per week, just in our lobby and you know, in our bathrooms, that our staff was really concerned about what do we do to help people, because we don't want them dying in our bathrooms, et cetera. And so we thought maybe we should have just an area of our waiting room where we could watch people who are sedated and we're really worried about, and we could have a nurse and people there to watch them. And that evolved, and I hope Jesse Gaeta, our doctors here, so this was the brainchild of one of our really wonderful doctors, who's our chief medical officer, Jesse Gaeta. And she has effectively, over this last year, set up a place where we actually bring people in who are heavily sedated, monitor them with blood pressures, and you know, we look at oxygen saturations. It's been an eye-opener into what the epidemic of opioid and other drug use has been. But I would say, first thing we had to do was convince a neighborhood that it was okay to do that. And that's when we ran into exactly this, you know, not only the stigma, but this is, I don't want this anywhere near my backyard. And Jesse and our CEO is Barry Bach, who's a nurse as well, spent a lot of time with the community around Boston Medical Center, talking to them about what they wanted and such. And interestingly, the community, after the dialogue went on for several times, the community realized this was not a place to draw drug users from far away, but simply to take care of people who were outside. And if anything, now we have the support of the community, because the spot is a place where people can come in and be taken care of, and they're not falling down outside. The drag of it, of course, is it's only got room for about 10 people instead of 40 people. And during the course of this year, we've learned a lot. One, we've sort of, whether we liked it or not, got involved in the conversation about safe injection facilities. This is not a safe injection facility, but I think the first thing someone asks is, are you letting people use there? And we're not, but what we do is watch people for hours if we need to, until the sedation is over and they can wake up. And what comes for our staff, certainly, and I would guess I see if there's ever going to be a hope that we can get the dialogue going with the wider community, is as you hear the stories of the people that are there, you start to realize, well, they might have looked just sedated and out of control on the streets. When you hear what they've been through, it's quite striking. You won't get, our nurses, for example, are phenomenally devoted to these folks now because they know their stories and they see them day after day. And when I heard Gary's talk this morning, it's the stories like that that make you realize, oh my God, we're all in this, whether we like it or not. So I've been a long fan of John because John started Friends of Boston's Homeless back in the 1980s when we were all struggling to figure out what's going on. And when I watched what he's done with the police officers, I realized that's a conversation I never dreamed was going to happen. And yet now the police officers will get on TV and say, we've tried all the other stuff, that doesn't work. Can we look at the new methods of looking at it? And they're doing it. So I'm hoping that those stories percolating through our society over time, despite what's happening at the government level right now, will be the change.
Yeah, go ahead, Jeff.
Good public policy leads to good public health outcomes. Bad public policy leads to bad public health outcomes.
Well, let me pause you right there and say the 21st Century Cures Act has not gotten the $500 million that was promised by this administration. So now what?
Yeah,
in addition to the other proposed cuts.
And I was at the White House for that bill signing. But in 1980, the HUD budget was $34 billion, and there were 200,000 homeless people in this country. When Reagan left office in '88, the HUD budget was $9 billion, and 2 million people were homeless. There's a reason. It's an affordable housing crisis. With gun violence, 90 more people will die today. There's no background check requirement for criminals, the mentally ill, and terrorists in 33 states, including Maine, New Hampshire, and Vermont. More
John,
people have.
That is not getting through to people. I'm just trying to get to how do you remove this stigma that nobody is believing you.
Well, that's not actually true because in Massachusetts we've reduced gun deaths by 60% since 1994 by changing the conversation. In Massachusetts, we've reduced homelessness, believe it or not, and we move a lot of people beyond shelter into housing as a result of changing the conversation about who the homeless are. And that we did it with talking about the working homeless, and we talked about veteran homeless. So to begin to change the conversation. With the opioid addiction crisis, there's no question when it was crack killing mainly black and non-white kids in the inner city, nobody cared. When it was gun violence that was perceived as just being a bunch of black kids killing each other, who cares? Well, we've changed that conversation by showing pictures on a billboard on the Mass Pike who's really dying of gun violence. And by talking about the fact you could fill Fenway Park up 3 times over with 110,000 kids killed over the last 30 years from gun violence, and half would be white and half would be non-white from accidents, suicides, homicides. So it is about changing the conversation. And with the Gloucester Angel program and the outreach program, and so the Gloucester Angel program invites people in, with or without the drugs, get them in treatment. The Arlington Police Angel program goes out and does outreach. If there's an overdose, they go to the home where the overdose is, they bring Narcan, they leave Narcan with family members, it's a soft handshake. They offer people into treatment. They say, look, when we've just taken your your drug dealer off the street with an arrest, rather than find a new drug dealer, how about getting into treatment? Because you're going to get a very different mix. You may be used to a certain percentage of heroin, and now you're getting fentanyl and heroin and you're dying, like my nephew did 7 months after I started the Gloucester Angel program. I had no idea, and many family members have no idea. So, reaching out, the soft handshake, getting people into treatment, changing the conversation, it's building trust. In Gloucester, we've also seen a 30% reduction in crime. So by talking about the impacts of opioid addiction on the community, the family, the budgets of communities, and we're finding that all of that has moved the needle to expose, and we've been disruptive. I mean, when you have a police department saying, our healthcare system has failed, we're going to fill in again in helping solve a societal bad public policy. And sure enough, we're seeing that that by exposing bad public policy and then proposing good public policy, you're seeing good public health outcomes. And I will say that we did landmark legislation in Massachusetts. The legislature and the Governor Baker passed landmark legislation. We are leading the nation, but we are not getting ahead of the problem. And clearly we need federal support in a big way. And in the absence of that, law enforcement is doing, what it can. But we have got to force the healthcare system. And we cannot let the pharmaceutical industry off the hook. This is like gun violence. It's all about selling guns. No background check. You don't let law enforcement know who buys guns. You increase gun violence. You increase fear. And you increase gun sales. No other country allows the pharmaceutical industry to advertise. 80% of people that end up on heroin or fentanyl start with legally prescribed painkillers. We are 5% of the world's population, and we consume 80% of the painkillers. We do not have more pain than the rest of the world. Right. So this is about greed, and it's about racism, and it's about bad public policy, because we are not participating in our democracy. And we are letting these pharmaceutical industry, the gun industry, and government get away with murder.
Well, okay, so, what I'm trying to get to is what can be some actionable ways, some right now, if you don't have good public policy, as we don't, if the money may not be coming for the federal government, what are you going to do?
So, and thank you for that. So my story works, and it works in front of people like the people in this room. People will applaud, in recovery for 30 years, he got a PhD, came from prison and did all that. Works, right? In some audiences, it's like, that doesn't work. I could care less. I don't give a shit what you did and where you came from. Some of that internal conversation that we all have, and some people don't say it out loud, but some people do. So I use my story whenever it's appropriate and in front of people that it's appropriate, because I think that it helps move the needle forward, particularly people struggling with substance use disorders and who need to hear from other people that recovery is possible. And so in those settings, I use my story in a very specific way, and that works. But many people have taken my story and said, well, if Hanel did it, anyone can do it. That is not true. Not with the system that we have in place today. And if we say that, we're not being honest. That it is uphill for many people, and it becomes this way for many more because we don't have what is needed in place. Now, to the issue of speaking to different audiences, policymakers, we need to think about the terminology that we use, the arguments that we make. Within recent years, this whole conversation on sentencing reform and mass incarceration came about because many people from both sides of the aisle, and I'm talking politicians, right? Right. Both Democrats, Republicans, independents, I said both, it should be all. Many on one side were saying, this is a human issue, a human rights issue, that sort of thing. Makes sense, right? So you make that argument with folks who are that inclined. Other folks said, no, the budget can't support it. And so you have to make the argument regarding cost-benefit analysis in relationship to that. And I think that, and police departments across the country, particularly here in Massachusetts, are evidence of this. Who would have thought that the places who would embrace change would have been police departments? Raise your hand. First in line, right? No one raised their hand because we didn't think that that was possible. Now, if you think about what happened is that it took a champion from within, you see? And that champion, not using I would think, a recovery voice, but using a different type of voice, help to move that needle to where we are today, where people across the country are coming to Massachusetts to learn what's happening here.
And that police chief went to the recovery community. And it was the recovery community that said, Chief, you don't understand. This is a disease, not a crime. You need treatment, not jail.
It's a partnership, right? So it's a conversation back and forth. So I think we use different languages, different voices for different things, and for different audiences. And we can do that. We have done that effectively. I mean, I was contracted to observe some of the first training that was done in Western Mass with police officers around Narcan. I felt sorry for the facilitator because 99.9% of those officers in that room were saying things like, I'm not carrying Narcan. If I catch someone with that, I'm going to take it from them. They should die. They brought it upon themselves. All of that stuff, right? Some of that 0.01% were female police officers in the room who said, I might carry it. You know, we can help people out. If we would have left it up to people in that room, if they wanted to do it or not, wouldn't have happened. It took the champion, a lieutenant, who said, this is going to happen, and we're going to train everybody, whether you like it or not. And the innovators come first, right? And then people follow afterward. We need to think in what science teaches us about human behavior and human change. So I want to say that. But I want to come to this piece on making people feel uncomfortable. I want to come back to that. That's a conversation that I like. Because we're talking about change. And we, in Massachusetts, how many of you saw the State Without Stigma campaign? Yeah? Most people raised their hands, you heard about it, all of that. That State Without Stigma campaign really geared towards everybody, right? I think that we can be most effective, or one of the areas that we can be most effective around stigma has to do looking inward into our system of treatment, prevention, intervention, treatment, and recovery support. So not just treatment. The way that we treat and deal with the people with substance use disorder is deplorable. We talk about frequent flyers. We talk about people who haven't done enough research. We talk about people who need to go out and do more drugs before they can come back. We play favorites. Some people are more inclined to get in than others. If I call because I'm Hanet and I know a lot of people, people will answer my calls and let someone into treatment versus, you know, someone, a mother or a father who's trying to get their son or daughter in, they're like throwing their hands up in the air. I can't get into this place. And we need a campaign looking inward. And this is tied to issues of decent wages, living wages for people who work in our field. You probably do know this, right? We pay our folks deplorable wages. And so we get people with very little training, some people with a lot of desire. We've pushed people out in recovery in relationship to this field. And we've done some things internally that perpetuate this system of discrimination and apathy. And I was asking a group yesterday, so what about empathy? And they, you know, everyone says, yeah. So where do you go to learn empathy? Where do you go to learn that? Right? There isn't a course about that. So where do you go to learn that? And we need a lot of looking inward because we like to point fingers at other people. Our field needs to look inward and change attitudes, beliefs, and behaviors around how we treat people because we don't do a really good job. I am a trainer. I go into places and people say, I'm non-judgmental. Really? I'm non-biased. Really? I treat people as they come. Really? I treat people the same. Really? Because all of it is a crock of shit meant for us to feel good about ourselves. We're highly judgmental, human beings are, and if you don't think that you're judgmental and you're sitting in this room feeling uncomfortable about that, you're judging me now. You either agree or you disagree, and that's a judgment, right? If you don't think that you're biased, when you leave here, and stand on the street corner and pull up to the street light, and you see that person who's experiencing homelessness, not the homeless person, the person experiencing homelessness, and there's a difference, right? So when you go up to that light, what do? You check if your windows are closed, you look away, you say, que cambie la luz, que cambie la luz, que cambie la luz, I hope the light change, I hope the light change, I hope the light change, right? Because we have been dehumanized. Now, if today in the park someone does damage to a dog, harms a dog, and at 6 o'clock news, we have people lining up to adopt the dog while they're stepping over the homeless person to get there and going, I don't want to look at that person. I don't want to look at that person. You want to talk about stigma? We need to look inward in our system, right? I took long, but there it goes, the uncomfortable feeling. Right.
I would only stop you because we have to give people time to ask some questions, and I just wanted to give a little roundup here as people think about what questions they may want to ask. So you've made it very clear that the action item should be looking inward. You have to find somebody who's a voice that people may not expect and move the needle, as Dr. Hernandez has said. Dr. O'Connell, you have to communicate with those in the community. They can first see and tell others and share the story. And you're about language all across the board so that we don't internalize those of us who wish to be supportive in this. And then in that way, sort of erase at least the surface stigma and begin then to look inward, as Dr. Hernandez has said, about the other real issues having to do with policy and having to do with discrimination and having to do with federal funding, lack thereof, whatever. So that's where we are at the end of this panel. And to remember that, as someone wise once said, the nature of reality is distorted by the mirror. So if our mirror is one that we look through with all of this kinds of ways of stigmatization, then it's really impossible to get where you are. So it's about doing that. Questions from the audience, please. Yes.
We're talking a lot about good and bad public policy today. Can you comment on specific policies that are particularly detrimental or specific policies that are beneficial? So this is the magic wand question. If you could wave a magic wand, what policies would you change?
Okay, I'll give you one. When you present to an emergency room with cancer, heart disease, diabetes, you name it, you're treated for the rest of your life. When you present with the disease of addiction, you're shamed, blamed, and stigmatized. So it is really bad public policy when the healthcare system creates barriers, and we need to develop and break down those barriers and have our healthcare system be blind to one disease versus another.
I'll give you 3 public policies: mandatory minimums, school zones, and private prisons, and services within those prisons that are private. Those are public policy issues. And right now in Massachusetts, we have some really good people on Beacon Hill who are proposing changes. So if you haven't heard, visit, for example, Representative Sonia Chang Diaz's webpage, contact her office. There's some bills that are making their way through the legislation around prison reform here in Massachusetts. Right. Do you know that we have prisons within prisons in Massachusetts? One of a handful of states is Massachusetts, that you can do up to 5, 10, 15 years in solitary confinement. Yes, here in the liberal Northeast, right? Well, you can spend 10 years in solitary confinement. You know what that does? Stay one day, when the snowstorm hit, did you stay a couple of days in your house? Remember what that felt like? Multiply that by I don't know how many times, right? And so that, in terms of public policy, there's plenty of opportunity for us to get involved as a call to action.
And on a federal level, I would say, you know, it sort of goes without saying, but you have to have a pulse to get into recovery. So even if our goal is for people to ultimately, hopefully, find treatment and find evidence-based treatment, we need to be keeping people alive and respecting people's dignity even when they're using drugs. And so an example of what can happen when you don't do that is what happened with Indiana, where almost 200 people, young people, got HIV because there was no access to syringe or injection equipment. And this idea that if you don't build it, people won't come. Within 6 months of starting syringe exchange in Indiana, that county returned 77,000 syringes. So we need, I mean, people are going to use drugs, and I think we have to accept that, but we have to make it as safe as possible, keep people alive, and then offer treatment that's appropriate and science-based when and if they want it.
I would throw something out, if I may, and it's on a much more prosaic level, but in reflecting what Dr. Hernandez says, if you go to a homeless shelter and somebody shows up for the first time and asks, where did you stay last night? It's about 50% of the time it was in jail. So one of the sort of the unintended consequences of the minimum, you know, of doing your mandatory time is that very few people come out on parole, and the minute they're released from the correction system, there is no one responsible for them. And that also turns out to be the time when, if you were using drugs before you went into jail, if you start using drugs then, that's when you're most likely to die. It's one thing. The other thing that has always horrified me, and I don't know why we don't talk about it more, but methadone arguably is one of the best treatments we have. But to get methadone, as a doctor, I can't prescribe it for somebody. If they come in and say, I really need help, can you prescribe methadone? I can't do it. You have to go to a clinic. And the law is that there are only very few clinics, and you know, one of the things we're learning, and the reason it's called methadone mile, because methadone clinics are actually great, except the rule is there's only a couple of them around, and everybody has to go to that one spot. Right. It's highly regulated, you know, and you think about it, and if I were going to sell drugs, I would go where 600 people that are really vulnerable are going to come every morning to this one little corner. And it's a crazy system. Right. Why aren't we just doing methadone like we do insulin? You know, I mean, we should be doing something like that, and we would eliminate a ton of the problems. So an example of a public policy that really, really thwarts treatment.
Could I also add, because it's coming up in the legislature now, there's a strong push to increase from 14-day to 28 or 30-day mandatory detox. In our experience through placing 535 people through Gloucester and roughly 10,000 across the country through the other police departments, is that the majority of people who are struggling with opioid addiction, heroin, fentanyl, need 5-6 days of detox and ultimately long-term treatment. So, I mean, the longer-term treatment, longer inpatient, outpatient, just long-term treatment, the more success. And it's not necessarily longer detox, it's long-term treatment for this disease, just like any other disease. And, you know, but detox is probably the most expensive, but maybe the least effective. So we need to change the conversation around getting long-term treatment for this disease versus just short-term detox.
I will say that just observing a lot of media, that I don't think most people understand how ongoing this is and how hard people are working to get off and how much they need to have the interaction and have to keep coming back. And it doesn't seem to be in the same mindset as people think it's so hard for me to lose weight in the same way. You know, they just keep thinking, well, you know, after 2 times, what's the problem? So I don't know what experts and those with the stories can get through, but that to me is one of the things that seems not to be able to help people understand this as a disease.
I would say also, I think just using the generic term treatment is actually problematic, because what passes for treatment varies tremendously. Actually, the vast majority of what we call treatment would be medical malpractice if we treated any other condition that way. And yeah, it's true. As for a funny skit, you should watch the SNL clip from last weekend about one of the gentlemen on the show actually talks about going to rehab and how he had to pay $40,000 a month for horse therapy to pet horses. And it's hilarious, and yet it's true. This is literally what people are paying for. They're bankrupting, they're selling their homes, they're taking out a second mortgage for what is called treatment, and yet there's no science behind it. We would not take someone who's struggling with breast cancer and tell them to go do yoga and pet horses or get confronted or yelled at. And so I think we need to be very thoughtful, again, about language, but also about really educating consumers. And we heard Gary say that we're all driven by the people that we care about and the people we love. And if you knew what the likelihood of success and the likelihood that that person you love is going to die if they get one thing that's called treatment versus something else that's called treatment, I think that will begin to mobilize change.
Can I say something very quickly about that? I read recently about 80% of our residential treatment programs are modeled after a 12-step model. 12-step models are free. AA, NA, GA, all of those things are free and available all over the world. And so why are we modeling treatment programs after 12-step models that are not treatment, they are recovery, support, and mutual help? That's in the line of making people feel uncomfortable. But I want to go back to not everyone needs treatment. That's not going to go over well with a lot of people. But if you speak with large groups of people in recovery, and I do all the time, I ask how you get better. How did you get better? Some of us, myself included, went to treatment. Some people went to church. Some people did exercise, yoga, and recovery. So there are multiple pathways of recovery. There are multiple pathways of recovery. And people combine those things and they work in many different ways, but we need to wrap our head around that. Not everything is, and we need more treatment. I'm an advocate for that because we don't have enough treatment slots. But that's not all that we need. And if we put our eggs all in one basket, then we're missing, I think, the point. In terms of medication-assisted recovery, some people call it treatment, medication-assisted recovery. Of course, we have really good data that says it's the most effective. There's a medication involved, there are doctors involved, and there's gathering of data. Can you do that with another pathway? No. So other things work also. And so we need to think outside of that box in terms of what other things work. And one of the things that we need to pay attention to is prevention. We don't do a lot of talking about prevention. There's some really good people in this audience who do some really good prevention work. And if we don't do prevention as we're talking about treatment and other forms of people getting better, it's very difficult to get in front of this, right? Because we're always going to be reacting. And so we need to wrap our heads around prevention and put the resources that are required for us to deal with this problem in a more effective way.
So Massachusetts has really become the leader, and you've got to get involved in encouraging your elected officials and your local police departments. So we have 34 police departments in Massachusetts that are entry points into treatment for anyone who wants it, and they're open 24/7. The conversation is starting to change here in Massachusetts about what and how to create the healthcare system that we need in order to treat this disease versus another. But at the end of the day, there's two choices. There's two options with this disease. It's long-term treatment or death. And whatever we can do, whether it's providing Narcan to first responders or Narcan to family members while we continue this conversation, go to your police department if they're not involved and encourage them to get involved. Go to www.paariusa.org. Look at the best practices of these police departments across the country. Encourage your police departments, encourage your family members in other states to get their police departments involved while this conversation around how are we going to reduce the 100 people's deaths from overdoses today.
So, John, I'm going to put you on pause because I'm really trying to squeeze this question in. Yes.
And that would tie into what somebody was saying about long-term support. So using peer support
that,
But the other thing that I'd like to raise, which may make people uncomfortable, is there are only two groups that are stigmatized to the extent that they can be forced into treatment. And that is people with psychiatric diagnoses and people with substance addiction. And nobody is forced into treatment for diabetes.
So is that your question?
Can you please talk to me about what you think about combating that form of stigma?
all right, so for those of you who didn't have it, she made a strong case for peer support in trying to help people through it. And the second question is, there are only two groups of people who are forced into, quote, treatment, and that's people with substance abuse issues and people with psychiatric disorders, and the panel responds.
Can I say something about
Yes.
You're talking about coercion. And by the way, recovery coaches in the room? Bunch of them. The work that you're doing with lived experience is awesome. Keep up the good work. In terms of coercion, we have many forms of coercion, right? So courts, jails, prisons, family members, significant others coerce people into treatment. Or you go, or I'll kick you out. Or you go to jail. I was one of those persons that went from jail to treatment. I said that earlier, right? Not because I wanted to, but because that was the choice. And so for many years, I said, coercion works, coercion works, coercion works. You know what works? It's not actually the coercion. It's the treatment that people receive once they're there. Once people are in treatment, if they're treated with dignity, with respect, if they're educated, and if they're brought from pre-contemplation into contemplation, preparation, and action, that is what works. That is what works. Again, it's a look inward. It's a look inward into our treatment programs, and it's a look inward into what we do. Some people might split hairs with me on, should we do away completely with coercion from the courts? I don't think that that's realistic, and I'm still struggling with that. But I do know this. What works is how we engage with people from the moment in time that we interact with them and humanize people, treat them with dignity and respect, and move them forward, and focus on what our messaging is regarding hope and support, access to treatment, access to many other things that people need. Many people came back from Vietnam who were addicted, right? I put addiction there in quotations. Most of those people never used drugs again. Most of those people never used drugs again. Why? The social determinants of health. Think about that. What was in place for those folks who never used drugs again to come back into society and to be productive members of society, and what did that do for those folks, right? And what happened to that smaller subgroup of folks who continued with a substance use disorder, many of which we see in our treatment facilities today and through the VA. There's some stuff there that we can learn from, is what I'm saying. And I'm a strong believer in many things, but also I think that with older age, I have the ability now to sit back and to take in some stuff like harm reduction. Very controversial here last year, but there's some folks who we're keeping healthy because of the things that we're doing, right? So to have that open mind is what I'm saying. And if you can't support something, just get out of the way.
All right.
Get out of the way.
Okay.
And what's unique about this law enforcement-based...
I got 30 seconds, John.
What's unique about the law enforcement-based entry into treatment is it's pre-arrest. So historically, it's been diversion through a police department. You're arrested, you're offered treatment versus jail. Of course, you're going to take treatment, but there's an 80 to 90% relapse rate with this disease, and if you fail, you're out. So this is pre-arrest, and it's access to treatment on demand, which is nothing short of what you'd expect with any other illness.
I'm sorry, we're going to have to leave it there. This has been a fantastic panel. Please join me in thanking them.
What a treat, John. What a treat.
head on back to the, thank you. Thank you, Callie and Sarah and Jim and John and Hunter. What a great panel, great folks, the great conversation. So we have one more brief set of remarks, and then there'll be a break for about 25 minutes. You know, we're all grateful to GE and to the GE Foundation for moving to Boston. And now I'm pleased to introduce Jennifer Edwards, the director of the U.S. Developing Health Portfolio for the GE Foundation, who will deliver a call to action.
Wow. Morning, everyone. And, you know, I'd like to thank Dr. Herzog and William James College for this just fabulous convening. I think the conversations so far this morning have just been fantastic, and I'd like to give another round of applause. So, you know, I'm delighted to be here. I think we're all here because we know that the conversation needs to change around mental health and substance use disorders. We really need to shift the mindset and the culture from a culture of shame and stigma and discrimination to one of support and understanding. And that is by no means a small feat, but I think the more we have these open conversations, the more we're going to start shifting that dial. As Dr. Herzog stated, GE relocated its corporate headquarters from Connecticut to Boston last year, and the GE Foundation did make a multi-year $15 million commitment to community health in Boston and across the Commonwealth. And our focus, we made, you know, after being out there in the community, doing what we call a listening tour for a good 4 months, talking to many folks in the health space, stakeholders, we made a decision to focus that effort on behavioral health and addiction medicine with an immediate focus on the opioid epidemic. So, you know, we see that it's really important to work together. There's already a tremendous amount of work obviously being done in this space. And the colleagues, some of the folks that we've been working with, the Dr. Sarah Wakemans, Boston Medical Center, I like to, as the layperson, refer to them as the rock stars in this space, and the commitment to passion they have is just unbelievable. So we as a company, we are committed to speaking out, speaking up, and speaking the right words to help, I'm going to use the word erase stigma and discrimination around mental health and addiction. So you heard many times this morning that addiction is a chronic relapsing disease of the brain. It rewires that brain. It is not a moral failing. It is not a character flaw. And we believe really that change starts with each and every one of you. It's going to take everyone to start moving a dial. So I was asked to provide this call to action. And I went, wow, that sounds big. It sounds like it should be something very innovative and creative. And as I kind of sat down and started reflecting on what I wanted to say, I started thinking about what I've learned. I mean, I'll be honest, I am new to the space. I've been running the health portfolio for the foundation for about 6 years now, and we have a footprint outside of the Commonwealth. And we've been focused on community health and community health centers, but we hadn't had this extreme focus on behavioral health and addiction. So I thought about what I've learned since we joined you all here in Boston last year and how I've been making small changes. So I realized that it's not one big change, it's several small changes that are not that hard. So as Hunter said, I'm not sure if I said his name right, as I go through these 4 things that I'd really like you all to commit to as you walk out of this room, think inwardly about how you are, you know, what are your beliefs, what are your attitudes, what are your perceptions right now, as you do come across someone struggling with mental health or addiction. So 4 things. First, know the facts instead of believing the myths and stereotypes. So we heard several facts this morning. Fact, last year, almost 2,000 people across the Commonwealth died from an opioid-related overdose. nearly one person every 4 hours. Fact, nationally, people are dying at a rate faster than those who pass from car accidents. Myth, and I'd like to say terrible stereotype, people choose to be addicted. No one wakes up one day and says, I want to be addicted to a substance. Again, addiction is not a moral failing, it's not a character flaw. It is a rewiring of the brain, a chronic disease that should be treated with the same compassion in our healthcare delivery system that we treat other common, complex conditions. 2, choose your words carefully. Language does matter, and words carry judgments, negative connotations. Individuals with mental health and substance use disorders are our friends, our family, our community leaders, our grandparents, our aunts, uncles. They are not addicts, they are not abusers, they are not crackheads, they are not nuts, they're not schizos. These labels are tremendously stigmatizing, and they put up incredible barriers for those individuals who are thinking about and want to access care. Those stigmatized labels throw up incredible barriers in our provider community for providers to adopt evidence-based treatments that have shown through science that work. So I know there's been a lot of discussion about medications. I'm going to use Dr. Whitman's definition of the acronym, but medications for addiction treatment. You know, that treatment is still sitting in the shadows of stigma. So how do we work to bring that out of that shadow? And as you heard from the last panel, the stigmatized and discrimination is leading to, you know, policies that need to be changed that are not. So we must continue that push and that movement so that people realize that mental health and addiction are diseases and should be treated with the same compassion as heart disease, diabetes, cancer. That's 2. 3, support those who are struggling. Those who are struggling, they could be our friends, our family members, our community members. They are our friends, our family members, our community members. Don't run away from them. Run to them. You heard Gary Mandel talk about the story of 2 boys. One was embraced, the other was shunned. And their paths couldn't be at 2 opposite ends of the spectrum. And we need to do a little bit more celebrating in this space. When you think about the celebration that occurs when a cancer patient goes into remission, why aren't we celebrating the journey of recovery? And why are we not celebrating those in recovery, just like you would celebrate those in remission? And lastly, 4, take time to educate others. If everybody in this room, as Gary Mandel said, talk to 5 people. I know I've been doing it. When the opportunity arises, I have that conversation. If you all commit to talking to 5 people and educating 5 people, we'd for sure, and I'm going to say it, let's think big, we'd start a movement. So 4 small steps that if each of you commit in this room can make a big difference. Know the facts, choose your words, support those who are struggling, and take the time to educate others. We're all here because we think this is important. There's been campaigns, the State Without Stigma statewide campaign. We have, I'm from the business, right, the private sector, so we've had companies, CEOs step forward. I know within General Electric, now that we have this focus, we are starting to focus it internally to our own employees. But there's startups out there. I know there's a bunch of tables set up downstairs, but there's an innovation down there called We Are Allies. They're a small startup that came out of the opioid hackathon that we had last September, and they're all about saving lives and busting stigma. So I urge you to go stop by their table, learn about them, and sign up to be an ally. We need more allies in the community that are supporting those who are struggling. So 4 things that you can do to start changing the conversation. And I hope that all of you would look inward and be a part of it. Thank you.
We'll see you in 25 minutes.